So welcome everybody to this monthly call for the Informatics Rehab Collaborative. I'm really excited because we have the opportunity to hear from a couple of physical therapists who work on the payer side and can share a different kind of insight compared to some of what we've been discussing in the past. And I think it's going to be really, really helpful for us. We are going to defer any comments from the IRC from anybody here. So if you have any additional things to share related to informatics in rehab, we'll do that after they finish up presenting. And part of that is because I know there's a couple people who have to drop off at the bottom of the hour. So Seth, I'm going to turn it over to you. I do want to just share, I met Seth the last 2 years at CSM. He has come to the presentations and we talked afterwards, and he shared and offered to share some of the information that they have from the payer side, which I thought would be really, really helpful, not only for this group, but for any of us who are out there working in the field. So Seth, I really thank you and Andrew for taking time today, for sharing a little bit with your analytics tool, but also anything you can share related to the provider perspective and how things are looked at there may be different than what you saw when you were on the provider side. So really looking forward. I'll let you take it over, and thank you very much.
Thanks, Bob. So yeah, thank you everybody for letting Andrew and I go over our analytics tool today. Yeah, I did meet Bob about 2 years ago. I love your lectures. I love going to CSM, of course, overall, but then I've kind of found that little home in the informatics space and love going to all the lectures. This year's definitely didn't disappoint. Andrew and I both work for Evolent. I'm not sure how many people are familiar with us. Evolent has gone under a couple different names over the past couple of years. You may be familiar with our company. I'm going to actually go to the next slide so you can see a little bit about us. Our company was formerly known as either Magellan Health or NIA. We were sold back in January of 2023 to Evolent Health. Evolent owned a bunch of other different properties and are bringing everything together under the Evolent name. So going forward, everything is referred to as Evolent. As far as if anybody is dealing with any of our programs throughout the country, the programs remain the same. Our portal RadMD, which providers will go there for authorizations. Primarily, they deal with us for authorizations in physical or be any of the physical medicine spaces. So physical therapy, occupational therapy, speech therapy, chiropractic care. We also provide service authorization and utilization management services for surgery. So hip, knee, shoulder, and spine surgeries. Advanced imaging and cardiac services. So it'd be more CTs, MRIs, some of the higher level cardiac studies that would be performed, as well as some of the invasive procedures that are now involved. And our other programs are radiation oncology, sleep studies, and genetic testing. We kind of do it all. Andrew and I are involved in the provider relations team. So we are not making the decisions on any authorization requests that anyone may be submitting. Our job is to work with providers and ensure that providers understand what's happening. You know, why did they get a denial? What's going wrong? If we're noticing provider trends, trying to make that outreach so that the process is as smooth as possible. I know I've worked with a couple of you that have had providers or work for an office that have had some issues in the past, and we try to do our best to help develop that relationship and answer any of those questions. With that being said, we'll go into our analytics tool. So as far as our analytics tool goes, it's been developed over, I don't know, it's been probably at least the past 5 years, if not even more than that, looking at the different providers we have for the different plans. I'm actually going to let Andrew take the next slide and we'll go from there.
Thanks, Seth.
There you go.
Good morning, good afternoon, everybody. Here's an overview of our analytics tool and our program. The main gist in its current form is to create conversation with providers, maybe even bring about eye-opening data points to them, maybe even a little self-reflection on how they practice and what they're doing, because this does give some good insight into where they're falling or where they are compared to other providers in a similar network doing very similar work. On that note, this is strictly derived from post-treatment claims data. So providers have rendered services, and then they've submitted their claims to the payers, and that data is then being shared with us by our clients, the health plans, so that we can run this analytics program to produce what you see in front of you. And what you see on the right is a snapshot of what would be an individual provider tool. This would be an instrument to, again, create discussion and share with the provider. And Seth is going to go into some of the details of that in the following slides. But we are using claims data specifically for this, recognizing that the nature of claims is somewhat limited. You know, we're just getting that CPT code data primarily, although we are looking to expand things, and Seth will touch on that as well too. But most of the time, when you're looking at analytics in this space, most providers at this point are using some type of EHR or some kind of analytics tracking within their own practice. And that does a great job. They can see trends and et cetera, but that's all they can see. They can't see anything outside of that. And this does give that expansion where they can see what ABC therapy is doing down the street and how they fall and compare to them. So it's truly trying to compare apples to apples, like providers doing like types of rehab in like settings within the same network. That network component is important, typically for like a geographic region. So you are seeing a smaller, more regional component with these network data reports. Furthermore, we do share this with the health plan and have them communicate with us to work towards identifying certain providers should they need further conversation or even preventing or combating fraud, waste, and abuse, as Seth will touch on in a few minutes. Other positive things coming out of it are looking at other benefit design, network optimization, and tier management. We currently are looking at about 2 years of prior claims data. With claims, there is a lag in the most current data, just from the nature of that space. So, for example, if we wanted to share with you today as a provider, the most current data we would likely have would be from about 6 months ago, would be the most current. And then from that 6 months would be a 2-year look back on that. Any questions on more of the overview and where this stuff comes from and where we're pulling it and things like that? Because Seth's going to dive deeper into the actual details of the card in a second.
Andrew, this is Bob, and I just have one quick question. When you say the data's from 6 months ago, I'm guessing that part of that has to do with the time for people to submit.
Exactly.
Does it? Okay, what if because I think they have up to a year to make corrections to that. So how do you incorporate that piece?
That would just be either included or excluded from that 2-year run window. The 6 months is a rough estimate. It does depend on the network that we are getting the data from. And like you said, that does have a factor of how long providers do have to submit claims and correct claims. So there's that whole process. And then plus there's a process of actually having the plan generate and share that data with us. And then for our teams to process it into our systems as well. So that all kind of ties into that lag. It's not as simple as having a claim performed today. It's immediately billed, immediately reimbursed today. There is that sometimes lengthy lag. So that's kind of where things fall.
Bob, Oh, sorry, Andrew.
Go ahead.
Part of the reason that we go with that 3 to 6 month window is that we're trying to get providers to show a little bit of change. If we waited to hold the data for a year, what ends up happening is that providers aren't going to get that. It's going to take a long time to show any change that they're making. So that 3 to 6 months allows them to start making the changes. Hopefully, they are submitting their claims a little quicker than a year out. There are many practices that do that, but we try our best. If they're getting their claims in, the insurer is processing them. We're hoping to give them the most current data. And so that's why we have that 3 to 6 months it takes between them having that run out period, the insurer processing it, and then us being able to process it to produce this tool. Looks like we do have a question in the chat. Hey, Steve, how are you? What is the source of your claims data? So we are a third-party company. This would come from the particular insurer that we're working with. One thing I'll talk about as we go into looking at the actual analytics tool is they're broken down by the particular health plan. So all of this data comes from the particular plans. Your next question was, how do you define active units? Active units is based on CPT codes, and I do have a list which goes along with this. So if we were giving this to a provider, there is a glossary that comes along with it outlining each of those areas. And then it looks like Diane has a question. Is there a market basket adjustment for cost data? Great question. This is a neutral fee schedule. So just because one provider's paid at one rate and another one's paid at another rate, that is not going to influence the numbers under the cost data points. Good question so far. So here's an example of one of our tools that we would present to providers. One thing Andrew did mention is that we try to match apples to apples. I know when I first saw the analytics tool, I was a little bit hesitant. I had my concerns when this was all brought to my attention because I had worked in hospitals. I had been an administrator in hospitals and had seen where we were compared. I worked in largely urban areas, and then they're comparing us to hospitals throughout the country, and I'm like, well, they're not dealing with the same issues we are. And when it came to this, I was saying the same thing to our team. I'm like, hey, we got to make sure that we're being cognizant of that. And what we've tried to do is break it down as best as possible. So again, we're looking only at an individual health plan when we're providing these. For many of the Medicaid plans we work with, it's not a fair comparison to just say, hey, we're going to compare you to every Medicaid across the country. The number of nuances that are involved in each of those contracts that a provider may have in the state of New York may be entirely different than what's happening in Texas or California. So we keep the markets, we keep the analytics tool within a particular market. Now, to break it down even more, we're looking at habilitative versus rehabilitative care. And the way that we go about specifying that is a provider will have that on when they're submitting their authorization request. And we define rehabilitative as, a patient was able to perform an activity in the past and is relearning an activity due to either injury or illness. And then when it comes to habilitative, those would be a patient is learning an activity for the first time. Many of those developmental disorders would fall under that habilitative care. Then we start to go by discipline. So for the physical medicine analytics tool, we have physical therapy, occupational therapy, speech, and chiropractic care. Obviously, it would not be fair to compare each of those disciplines to each other. So we've broken it down there. If you have a practice that has PT, OT, and speech in it, you would receive separate analytics tools for each of those disciplines. Now, you may receive multiple if you're treating both rehab and habilitative. And then if you're treating in multiple practice settings, there are additional ones. You may receive up to, for one discipline, you may receive up to 6, just because we are trying to keep it as fair of a comparison. Andrew did mention the 2 years that we do look of claims data that we do look for. For this particular example, we're looking at data from July of 2020 through June of 2023, and then a comparison period that's just 1 year prior to that. What we did, the reason that we're looking at the 2 years worth of data is we want providers to see how were they before, how are they looking now, and then we want them to see how do they compare to the network average for the current period. And that's what you're seeing here under the average utilization. The next three categories that we look at, or the next three columns we look at, are the total number of patients, visits, and episodes. That's just the tally of the data that we received. And then we start to get into some of the other information that they're going to have. So visits per episode, units per visit, units per episode, sorry about that, units per visit, and then RVU per visit. Now you'll notice that two of those columns are colored red. We will highlight providers that do classify as an outlier based on the network average. Yellow would be within 1 standard deviation, and red would be 2 or more standard deviations outside of what would be considered the norm for that network. In this particular provider's case, their visits per episode are significantly higher than the network average at 5.9. And then under units per visit, we're looking at 3.8 versus 1.4. This one, I know that we've received questions in the past about, well, 3.8 units per visit doesn't seem that high. This particular one is based on the contract that they have. They are using, I believe it's S or G codes for this particular contract, so the numbers should be closer to 1. As far as the visit count comparison, you'll see that the large gray bars, that is the provider's number there, and then the actual number is just below the gray bar. The network average is listed by that dot, and then the number listed above it. What we're looking for is generally providers will have it where it'll be a larger mountain here towards the beginning and then start to tail off as we get towards 41 or more visits per episode. And we define an episode as the time from the point that the patient is evaluated for a particular condition until the time that they're discharged. So generally for most patients, you're going to see somewhere between that 1 visit through about the 18 visits, or where the bulk of the visits are generally going to lay. In this particular example, this provider on average is keeping their patients in therapy for a while. Now, one thing we haven't really talked about so far is what do we do with these tools? The whole idea of this tool is to have a conversation. It's to talk with a provider and go over what we're seeing. So you look at that visits per episode and you go, oh, it's in red, uh-oh. It's not to penalize the provider, it's to talk to them and try and understand what's going on in their clinic. Are they seeing a particular patient type that does require them to see them for more visits? As far as the units per visit, what's going on in that case? Is there a reason that they're having to bill more units per visit than the average would be? And then as far as that visit count comparison, again, it's looking just like at that visits per episode. Is there a reason they're seeing their patients for a much longer time? You start to go into the cost data and you look over there a little bit. Of course, the cost per episode is going to be high. You look just to the right of it and the cost per visit. Yes, they're slightly below the network average. So the top bar, that is the provider's number there. So $115.36. The network average is $141.37. But they're seeing their patients for more visits per episode. So that's where that cost per episode is going to be higher, and they're just under $800 more per episode just based on the number of visits. Now, back in 2017, we were looking at using the evaluation codes as Medicare was and potentially looking at reimbursement. We actually use it for a little bit different factor right now. We look at the complexity of the evaluations and try to compare it to this visit count comparison. We have a number of providers that you'll see most of their patients fall under that low complexity. But then you go up to the top and you look at the visits per episode and they're well above the network average. And you're going, well, why is that the case? You're seeing a patient that you're identifying as having few comorbidities, relatively simple, and yet your visit visits per episode are significantly higher than the network average. It's just a question to ask and try and learn a little bit more. So the
Seth?
example, yep, yeah, go for it.
Yeah, just so you know, there's two questions that are in the
No problem.
chat area. I don't want to interrupt because you're going along with some great info, but I did want to point
I
those
get to
out.
it. No, thank you. So, okay, Stephen gave me a question. Thanks so much and understanding. Both would need to be on a panel or some submitted claims.
Oh. The one that I see is one that to get a comparison of different practices, both would need to be on the same panel that you were describing a moment ago. So on your previous slide. Is that correct? Or how would you compare two practices?
This
And
is gonna-
Stephen, if you want to, you can unmute and ask too.
Yeah, so great information, first of all. This is really good. Yeah, my question is, if you're comparing two practices, but one isn't paneled on that health plan, or you don't have data on that health plan, I'm assuming you can't compare.
they're all par providers for that particular network, so they would be on the panel.
Okay, they would need to be on that panel for you to make the comparison.
Correct.
Okay. All right, thanks.
No problem.
And Seth, the second one was, is there any further breakout of the metrics across diagnoses codes? And I think that was on your next slide.
Yeah, let me go over to this. So there is a little bit, we have a little bit more on this slide. This is the outpatient one. As far as comparing metrics across diagnosis codes, I'm going to be honest with you. There's a lot that Andrew and I would like to do to this analytics tool. It's getting the resources and bringing those resources in to make some of the changes. One of the things you'll notice with it is we're a company that does authorizations. There's no authorization data on here. And so that should be included as part of it. How are providers doing when it comes to submitting those authorization requests? Some of the other areas we're looking at are outcomes. How are providers doing? What are the patient outcomes? We measure it indirectly at this point. We don't have a direct way of seeing how did the patient do long term. Some of the other areas are how does this impact other areas of the patient's care? It's just not there. One of the questions that was brought up to us recently was, even an age comparison. How are your patients how are the patients for Clinic A versus Clinic B when it comes to age? There have been questions over complexity of patients, and currently we have this analytics tool as well as one that we use with our musculoskeletal program or our surgery program. Now for that one, we do have a average patient risk score, which is looking at the complexity of the patients. What we found with that is it doesn't really factor in as much as you would think. I know that when I would look at my data in the past and I'd think, oh, well, I see a tougher patient than the guy down the street. What we found is that it doesn't really impact the data as much as we thought. But something that potentially will be added to here and something that we've talked about and we've brought to our administration is something we would like to see. So getting back to what we have up here on the screen. So this is an analytics tool that you would see for an outpatient office. So this is physical therapy for a rehabilitative patient in an outpatient office setting. Those times that I mentioned before are the same. So the current period and the comparison period are July of 2022 through June of 2023, and then the year prior to that. Under the average utilization, the categories are all the same. This provider, unlike the one on the prior screen, is within the network average, so you aren't seeing any of that yellow or red. One of the things that we have found interesting when presenting this to providers is that when it comes to areas like RVU, many providers have no idea what we're talking about. And so it's one of the areas we've actually, in a sense, we kind of skip over it, because when we start talking about it with providers, they get confused and it causes more of a problem. Some of the areas we did add for outpatient are looking at the use of modalities. For the first one, it's the number of visits with multiple modalities, And then the second one is the percent of units that are modalities. So we know that there is a time and a place for modalities, but how effective are they in the true treatment of a patient? We'll find that there are providers that are using modalities all the time. There was one I looked at a couple days ago where the provider was using it 50% of the time with their patients. I'm not sure that that's necessarily the best use of time, and from what the research shows, not really the best way to go. One of the other areas is looking at active versus passive care. And I know Steve had brought up the idea of what do we define as active and passive care. That is in our we do have that broken down. It is based on CPT codes. And we define it as that we're trying to get patients to be more active in their therapy sessions. So an active activity would be one where they're actively participating versus passive care, where something is either being done to the patient by their therapist or a modality. So we're trying to encourage more of that active end of care. So we look at that and then the passive care here. What you're seeing again is that visit count comparison, which was the same as we talked about before. As you're seeing on this graph, it's more of that mountain where it's higher towards the beginning and it gets smaller as we get further out. This is more of what you would expect to see. The cost data, same thing as we saw before. Their costs are a little bit high per visit. That's what's making up for that difference that's over here. There is an area, one of the areas that Andrew and I were looking to get removed was actually this area down here, the active and passive care units, very similar to the data that we presented up above. So looks like we do have a couple other questions. And of course, if you do have questions about what I've shown, feel free to ask. Hey, Sam, what other ways do you measure complexity of patients aside from comorbidities? As I mentioned, we're looking at other ways of adding that to our analytics tool. It's not quite there just yet. Rick wrote, does the report the frequency of different CPT codes? It doesn't report that.
Not currently, no. That would be a nice data point though to have a breakout of how much the percent of the time is 97116 being used, 112, 53, all those codes. That could give better insight into treatment patterns, outcomes even. But currently it's not at that level yet, but is something that Seth and I had discussed and hoping to expand as this continues forward, along with other things as well, such as diagnoses, et cetera.
Sam has another question here. I find visits per episode sometimes not as clean as I would like, especially when there are multiple diagnoses, workflows, and EHR, etc. How do you account for potential documentation or coding errors by PTs? Great question there. Again, keep in mind, this is a conversation. We're showing the data that we've got. We want providers to understand we are collecting data. Every insurer is collecting data on you. If anybody thinks that they're not, I hate to tell them they're incorrect. Everyone is collecting data on you. Our goal is to show you, here's some of the data that we've got. This is to try and help providers understand what's going on, how do their practice patterns compare to other providers within the network. We're having a conversation with them. So if there are multiple diagnoses, we're seeing a more complex patient and the visits per episode are on the high side, that would be what would come out during that conversation. It's something that we would take back to a health plan if there were any questions about it, things along those lines. How do we account for any potential documentation or coding errors? Again, it goes towards that same conversation. I will tell you, we have actually found fraud using this tool. It's been some really sad stuff we've seen. We've seen as far as units per visit is generally where that will be picked up first. We found a PT was billing, it was over 10 units per visit on average. So that means they're seeing their patients, depending upon, if we're going to go with the 8-minute rule, it's going to be somewhere around 2.5 hours. If it's not that, they're billing a lot of units in a short amount of time. We had a speech therapist that was billing on average over 3 units per visit, which for speech, they're generally using code 92507, which is a service-based code. So their numbers generally tend to be closer to 1. So seeing somebody at 3 gets a little bit concerning. We ended up finding out they were throwing in all sorts of codes to run the bill up. Steve wrote, how are you encouraging more active care? That's through our educational program. We meet with providers to go over what's going on, what we're seeing as far as how they compare to providers, and we try to encourage that. There was a program we had in the past, part of our authorization programs, where we were actually approving it was patient units. It wasn't visits, it was actually units. And there was a part that was actually approving active units versus passive units. That has since gone away. But right now, the way that we do it is through education. Sam wrote, do you also take account for repeated patients who are coming in for a similar condition? It's something that it's actually going to be in here. You're going to notice it with the total number of patients and the total number of episodes. So it is accounted for in there. And don't worry about the questions. I love questions. Stephen wrote, you mentioned you have some data on outcomes. What are the outcomes you have data on, and how do you get it? We don't have that data. What I was saying is that's something that we are currently looking for right now. The way that we are looking at outcomes is indirectly. We're trying to look at it through claims information. For instance, with our musculoskeletal analytics tool, it's looking at advanced imaging, how many CTs and MRIs are ordered after a patient's had knee, hip, shoulder, or spine surgery. How many of those patients are receiving injections after that spine surgery? How many are on narcotics? So it's looking more in an indirect way. We are looking at trying to find a way to get that outcomes data. It's been a little bit of a challenge. At one point, we were looking at using the outcomes registry. Obviously, that's gone away. And so it's at this point trying to figure out how can we go about getting that data. Jason wrote, do you find the conversations go both ways? Are you in any way taking findings from a given clinic and aiding in advocacy back to the payer on behalf of the clinic? Jason, that's what I do all day long. So I will tell you that having Andrew on the side we're on right now is such a huge benefit to therapy as a whole. We have stopped all sorts of policies and different things from happening because we both have experience in the clinic. And many times when it comes to some of the people we work with, they're putting a policy in place and we're like, hold up. In a clinic, that's not necessarily the way things work. And you may want to look at it from this perspective. As far as advocating for a particular provider, I do it all the time. That speech therapy provider that I was talking about before, that we found that their units per visit were at 3. The health plan was going to take them to what's called their SIU. They were going to investigate them. It's a special investigation unit that looks at providers that are involved in fraud, waste, and abuse. In that case, I don't know that it was fully the provider trying to commit fraud. I think some of it was an education thing. And so in one of the meetings we had, I actually explained to them, look, we've met with the provider. I feel that there is a portion of it that is they need to be educated on, and they need to fully understand what they are submitting claims to say. And so in that case, we did help them to not have that SIU start to look at them fully. A full investigation can lead to all sorts of things. The plan can report them to the state, can drop them from their plans. They can do all sorts of great stuff there. Sorry, I'm getting back to the questions a little bit. And as far as the conversation, sorry.
Seth, I'm going to interrupt and just ask a question back related to the outcomes you were talking.
Yep.
So if you come back to a provider and you start communicating with them and you're showing them this data, and they could then say, well, here's our outcomes for those patients. Let me narrow it down. does that give you additional insight to go back to your people and get the okay, if you will? Does that influence that process?
Yes. So with the information we're getting here, I guess the biggest thing I should say out of it is that the conversation, we're taking that back. If there was any special program, I will tell you right now, nothing is done with this. We're not there's no punitive thing that occurs as a result of this. But if we were going back to a plan and wanted to talk about a provider, yeah, we would take back that information and say, hey, this is some of the reason that this provider's numbers are a little bit out of whack. You know, they're treating a particular type of patient, their outcomes are looking really good. Maybe we should look into this. Why are there, you know, they're seeing patients a little bit longer, but their outcomes are better long term. Another question here. Have you done any correlation with providers using more active codes, and downstream cost surgery, imaging, medications, injections? Again, something we're looking to get added. We have it where on our musculoskeletal tool, that one does look a little bit more at that. We're hoping to get some of that added to this tool as more resources are put forward towards it. Sam, sorry, he's got to drop off. Sam, I hope I answered your questions on that tip sheet I sent you. You had asked me about questions about the tip sheet a couple weeks ago, and I sent you some answers on that. Did I answer everything you needed there?
And while we're waiting for Sam, the tip sheet that Seth is talking about, Madeline will get that over to you and we will be able to post that onto the website, just so everybody knows.
I'll pull it up.
Thanks, Seth.
I'll pull it up in a second. Sam's asking, could you explain how the issues were dealt with on your end? Was it reported? Generally, what's happening is we'll go back. When we're meeting with a provider, one of the things that we'll do is we'll try to have the health plan involved in the conversation. When we first rolled these out, we had conversations with providers and didn't fully understand their contract nuances. Within a particular plan, you may have one provider that's paid on a per visit basis. So we went to a provider and actually had this happen where we're showing them the analytics tool. We're going through this great speech that we've got. And then the provider goes, why do you care how many units per visit I'm submitting claims for? You go, I'm paid at the set rate. I could bill 20 units. It doesn't matter. And so what we've done since is we've engaged the health plans even more so that their representative will join us during these calls, understand the contract a little bit better before reaching out to the particular provider. And then we do bring it back. So it's going to a higher level, more than just the PR rep from the health plan. When we meet with the administration for the plan, we do discuss this stuff. Looks like that's all the questions there. I can show you a couple other tools. Like we have one here. This is OT, very similar to what we have for PT. Is most of the stuff that they're going to be submitting their claims for in the outpatient space will be very similar. The one I did want to call out real quick is speech therapy. Speech is a little bit different. Their use of modalities isn't as much. There is some use of modalities nowadays, but not as much as you would see in the PT space. We're looking at codes over here like that 92507, seeing how much providers are using that, and then how much are the patients also involved in another non-speech treatment on that same day. So that's the speech side of it. Any questions on the analytics tool? Of course, if you think of anything later on, feel free. You're welcome to shoot me an email.
And anybody can unmute and ask if you don't want to be typing it in or you want to give additional context. Just unmute your line and share your questions. I'm not seeing any additional questions, Seth.
Let me bring this up. I'll show you a little bit more about that. I was talking that tip sheet that we have. For anybody that didn't get it, feel free. Bob is more than I gave it to Bob. He's welcome to share it with whoever would like it. What we've created is we rolled the programs out for physical medicine. We found there were some areas that providers had some difficulties. We do have our portal. This goes over the questions that are generally asked on our portal. So when the front desk staff is submitting the authorization request, some of the questions they would be asked used to tell providers to cut the top half of the sheet off, and they could give it to the therapist and have them fill out the answers, and it helps speed them up through the process. This goes over some of the documents we do require at certain times. So providers always want to know what documents we are looking for. Our process does involve initially when they're submitting a request, an algorithm that is looking at, is this really a request we need to look at, or is this one that's going to be approved? A patient that just had a knee replacement needing outpatient care. We all know that one's going to require some care. So that would be approved for a certain number of visits off the bat. But in other cases, we will require documentation. In our particular case, we are a little different in that our reviews are conducted by like discipline reviewers. So a PT is reviewing PT cases, OTs are reviewing OT cases, and speech therapists are reviewing speech therapy cases. So there's the documentation. We do have a little section here on some of the details that need to be included in notes. So I've learned a lot having come over to this side. What we found is that providers will do all sorts of crazy stuff. We get notes that have been copied, like exact copies of notes submitted for patients that are completely different. Last week, I got an email about a provider that was submitting notes for speech therapy. One patient was 2, the other was 60, and it was the exact same note. So you get crazy stuff like that. One of the other things I had a conversation with a provider who's telling me, I submitted all the documents you told me. So what I'll do at that point is I'll do my research. I'll pull up their request. I'll look through the documents. Yeah, there was nothing in the notes. Like if they handed that note in school, they would have failed. The note contains no data at all. It was for range of motion, it was within functional limits for everything. Strength was greater than 3 out of 5. And when you looked at the assessment, it had the diagnosis. The goals were as vague as they come. There was no time frame on it. And so why did they get denied? Because the note said nothing. So a very common problem we run into. One of the things we did include
I'm just going to call out really quick. Thank you, Andrew, for being here as well. And now you have to drop, but thank you. Keep going, Seth.
So one of the other areas that we have on here, and this is really the key section that we use all the time, are some of the common reasons for authorization denials. The first one we talk about is what's called the lack of information. So our reviewers, when they are looking at a request, they are looking at the therapist's documentation. Many times we don't receive the initial evaluation, the plan of care. We may not receive reevaluations, some of the daily notes. Things that would be included with the note, we're just not getting it. And so a provider would get a denial for lack of information. Now, the next one is the number one reason for denials across the country, every single health plan, our plans, other plans, this is it. We as therapists do a terrible job of selling ourselves. We don't explain where our services are needed and what are we doing as therapists during these sessions. We go ahead and a lot of the time it's continue per plan of care. You're getting not much written in the note. We have to sell ourselves better. We have to explain that the patient's not just walking into our clinic, using the equipment and walking right out the door, or that we're not just giving them verbal cues and calling that treatment. We are not great at writing notes and explaining what's skilled. We're actually pretty bad at it. And it's not just PT. OT does the same thing. Speech is right there. And I'll be honest with you, chiropractics are the worst. Their notes are awful, and they don't do it at all. Some of the other areas, lack of progress. We've all learned about that one in school. The thing I would say with that is explain it. if your patient's not making progress or they've plateaued for any reason, it's explain what's going on. Patients had increased swelling. Patient was sick for a couple days. We had a case where there was a kid that the kid looked like they were non-compliant. It looked like they just were non-compliant with their program. Turns out that mom had just given birth to one of that child's siblings, and she was the main form of transportation for that child, and they just couldn't get the therapy. That should have been in the notes. If that was in the notes, it made things a lot clearer as to why that child wasn't making their appointments and why the progress wasn't there. We get into two other areas that these two get a little bit more controversial, but when you look at the excessive request, it's explaining based on the patient's condition why the number of visits, were being requested. We get providers that will put in these ridiculous numbers. They'll ask for 100 visits. They'll ask for crazy number of visits, but then when you look at the notes, patients, at or near their baseline level. When you look at their objective tests and measures, they're scoring in an area where it's considered a normal level, but there's not an explanation as to why that number of visits is needed. When it comes to frequency has also been one of those areas where providers aren't great about explaining themselves. We understand early on in care, the patient may need care 3 times a week, maybe even more than that. But as their program is continuing on, potentially scaling that back a little bit. If they are on a particular protocol or there's a reason for that high frequency, just calling it out in the notes and explaining exactly what's going on and why that increased frequency is needed. Overlapping authorizations. Overlapping authorizations is one where we try to prevent patients from being seen in 2 clinics at once for the same condition. As crazy as it sounds, you might figure, hey, I would go to 1 clinic for my condition and get treated there. Providers try all the time to play the system, or patients, mind you. What they'll do is they'll start at 1 clinic. A couple days later, they'll go to the other clinic, and then they'll try to decide which clinic do they like better. Or maybe they feel if they go to 2 clinics, they'll end up being better. So our system has it set up where it will block that from happening. So we'll get the first authorization request, and if another provider tries to submit the authorization request, it will block them. Now, there are some exceptions to that. And that would be in those cases where it's a specialty. So it would be lymphedema and maybe an orthopedic condition where neither clinic sees both. Then we go into some habilitative. I'll stop right there. Habilitative cases would be the rest. So if anybody has any questions, feel free to shoot them over to me. Sorry.
No, you're fine, Seth. I have just a couple of questions, but I also want to share updates. I guess my one question that comes up, so as we are thinking about this from an informatics perspective and such, one of the pieces that comes in, at least for me as a provider, there's this challenge back and forth between payers and providers. And it sounds like you are starting to break that down within Evolent, and I really, really appreciate that. How do we also get PTs involved with other providers to do the same thing, or other payers, I mean, to be doing the same thing to break that down? And I guess maybe it can't be answered here, but it's a thought that comes to mind as you're going through this.
I'm going to go in a couple different ways with that question. One, it's looking, for people, there's all sorts of sites out there now for people that want to get out of the clinic and into a non-clinic role. There are jobs available at many health plans. Now, just like we've talked about in a lot of the tech sig and some of those other areas, it was brought up. It's talking to people. We do have a place in an insurer. We need to be more present. Right now, most of the decisions are made by non-clinicians. Other decisions are made by doctors, nurses that don't necessarily understand what's going on. We have it happen all the time. There are many times where I have to step in and say, hey, this isn't going to work. Now, the other thing is encouraging people like myself that are going or that are working for these companies to speak up. I will tell you that when I first went to CSM, I met some of the people I went to school with and told them who I worked for. And I got the look of death, and I got some nice words said to me. What they don't realize is I'm actually advocating for them. If they, by doing that, it doesn't necessarily make you feel the best.
Well, I'm going to say thank you for being there and doing it. And thank you for coming up to me both times, because it does help to break down some of the concerns I have with, especially with some of the Medicare Advantage payers. So thank you.
No problem.
I do want to shift just a little bit and go to a couple of updates, and then we'll go around the group in case anybody else has updates to add as well. And again, first, I just want to say thank you, Seth and Andrew. First update that I have, just so everybody's aware, the LOINC conference is coming up in September in Washington, DC. Their theme is making interoperability easier, and they do have it, it's open for proposals until May 31st. I'm going to post the one proposal here in the chat. I mean, the link to the proposal area. Second thing that I had was there's a call for papers out for special issue in the Journal of Geriatric Physical Therapy. And so they have that. I'm going to post that link here as well. Just if anybody has any research that you're doing or any of your informatics stuff, it's actually a PDF. So let me see if I can still put that in here. I'm not sure if it goes or not, but if it does, then at least you can take a look at that as well. Those were the only two updates that I had. I do want to go around the room really quick and see if there's any updates from others, either things coming up, presentations that you're giving, or papers that you've done recently. And Steve Wilkinson, I'll start with you, and then I'll go with Rick Black second. And again, this is just if there's any updates any of you have related to anything with informatics and rehab. Steve, any comments from you? And you're still on mute if you do.
No
Not seeing.
comment.
Thanks, Steve.
Yeah, I don't have anything to add. Thank you, Bob.
All right. Rick Black, will go to you next, and then after you, we'll go to Stephen Hunter. Rick?
Bob, no, I don't have any updates. Thank you.
All right. Stephen, will go to you next, and after you, we'll go to Kristen Beasley.
Yeah,
Stephen?
nothing more from me, Bob. Thanks.
All right. Kristen, will go to you, and after you, we'll go to Queen. Kristen?
I don't have anything to add. Thank you.
All right, Queen, we'll go to you next, and then after that, we'll go to Alan Lee. So Kristen, Queen.
No, I don't have any update. Thank you.
All right, Alan, we'll go to you next, and after you to Lucas. Alan?
Oh, no, nothing to add, Bob. Just nice to see everybody. Seth, thank you for your presentation.
Excellent. Lucas, we'll go to you next, and then to Andrea. Lucas?
Wish I had something to add. Just, nothing to add. But thanks again for the presentation. It was great today.
Perfect. Andrea, we'll go to you next. And Matt, I already see that you say no in there, so all good. Andrea, anything to add?
No, I don't. I guess I'll just say that it's been great working with Seth. I represent APT Indiana, and we've had just some conversations with him, and so he's always been very helpful. So I appreciate your help, Seth.
Really cool to hear that too. Seth, anything that you have to add about anything else, and any other last comments that you want to share?
No, feel free. If anybody has any questions, or, feel free, just reach out to me. I can put my email address in the chat. But feel free, if anybody has anything that comes up, feel free.
And I will just add, Seth, I know when we talked at CSM, you shared that if we have issues with other payers, that sometimes we can still talk with you just to gather that insight from the other side as we're still working with them. And I just appreciate that thought and such.
If you have questions, I'm here to answer questions. Feel free. You're welcome. I can even post my personal email if you feel it would conflict with my work. You're welcome to email me there as well. But yeah, if you have questions, if it's an evolent question, feel free, just reach out to me. If for something else and you have a question, you know, I'll do my best to answer it for you.
Really appreciate it. There is a comment here that was about any CSM presentations. And I know that there have been some, I hope several were put in related to informatics. It is still open if you want to do one of the poster presentations or panel sessions. So if anybody has something short, might be good. And as I think about that part, Seth, it might be kind of neat if you guys propose to do essentially what you did here for one of those panel sessions too. So just thoughts.
I'd love to if we did. My team didn't go from 14 people down to 6. So we're struggling right now. That's why Andrew had to jump. But definitely something to think about. I'll talk with him and we'll see what we can do.
All right. Sounds great. Thank you, everybody. Have a great day. Thanks for your time today too.
Thanks, Bob.
Thank you.